Morgan, we know that you've recently taken the opportunity to do a really interesting study developing a really large body of comparative data for Clareon versus IHANS. Could you share a little bit about that study?
Absolutely. So it was a 310 patient study. It was prospective but non-interventional. So these are patients that had already had cataract surgery, and we brought them in 155 patients in the Clareon group and 155 patients in the IHANS group. And I think it's important to note that these were not just our first 155 patients in each category. We've done, as a practice, over 2,000 IHANS lenses and nearly 7,000 Clareon lenses at this point. So we had a large pool of patients to pull from for this study. This study in particular was really looking at what is the difference in the defocus curve, or is there a difference? And what does the distance-corrected intermediate visual acuity of Clareon look like compared to IHANS? Is it non-inferior? And that's really what this was. This whole study was powered as a non-inferiority study. And we did an analysis starting with a step-down approach. So the primary outcome was actually looking at target-corrected intermediate visual acuity. And now a lot of people say, well, that's not apples to apples. And they're absolutely right. That part is not apples to apples. But the secondary outcome measures were distance-corrected intermediate visual acuity compared to distance-corrected intermediate visual acuity in an apples-to-apples basis. Now, the target offset was determined. The reason I did that was because I had heard just at meetings and trade journals that if you defocused IHANS plus, if the patient came out plus a quarter, you may lose that intermediate benefit. And so we thought we'd do the reverse and give Clareon monofocals that minus a quarter extra on the defocus curve in order to just to see where those would line up. And of course they were non-inferior. Clareon was non-inferior to IHANS in the target-corrected intermediate visual acuity compared to the distance-corrected intermediate visual acuity of IHANS. But the apples to apples, the really, what to me as a surgeon, what is most clinically relevant to me is that head-to-head, apples to apples, DCIVA to DCIVA, both set to plano through the phoropter, Clareon monofocal IOLs are non-inferior to IHANS monofocal IOLs.
Yeah. And I had the opportunity to see the defocus curves for the non-target corrected comparison, and it was striking the extent to which those defocus curves, even without the target correction for Clareon, basically sit on top of one another.
Yeah, so that defocus curve is an apples-to-apples comparison defocus curve, so both patients set to plano and then defocused from there. And that really shows, I mean, that they're quite comparable in terms of the defocus curve.
So the overall conclusion of the study, Morgan, was that there wasn't a clinically significant benefit of IHANS versus Clareon. So how did this study sort of change your thought process, and how should it change our thought process as we consider the monofocal plus category, if indeed it even is a category?
Yeah, it's one of those really important things that's going to become more and more important as all of these new lenses get introduced over the next couple years. I think that when we look at the monofocal category between that laboratory single focal point, true just point, compared all the way to the ANSI criteria, which are our EDOFs, if we zoom in on that spectrum, is there a place where these monofocals fall in terms of their depth of focus? And is it clinically significant to the patient? Now, this study in particular didn't look at that, but none of these monofocal lenses meet the ANSI criteria. That's why they're monofocal lenses. So
it's interesting that you bring in the ANSI criteria for EDOF lenses, because one of the four key criteria, of course, is that an EDOF lens should extend the depth of focus by at least half a diopter at 0.2 logmar. And in fact, as we've said in this study, the defocus curve for IHANS sits exactly on top of the Clareon monofocal defocus curve.
Yeah, and the other ANSI criteria that's so important is the one that speaks to consistency, right? So you have to have an improvement in intermediate vision greater than 50% of patients. And we just don't see that with many of these monofocals. That's, again, why they're monofocal IOLs. We do see patients who get intermediate vision with monofocal IOLs, and that's not something that's new. There's lots of data that supports that, but the marketing around it has changed recently.
So Morgan, having had the experience of doing the study and having gained the insights that you have gained, what advice would you actually have for other surgeons trying to navigate the complexity of all of these monofocal offerings currently available?
So I would first of all say, try them. I think it's reasonable to try new things. But when you do, make sure that you're, again, comparing on an apples to apples basis. If you're looking for a lens or something that does more than what your current technology does, or you're told that it does more than your current technology does, the best way to evaluate that is to, again, put it on an apples to apples scale. And what that means is, if you're targeting emmetropia in all these patients, that's different than mini monovision, and that's different than monovision. And so if you're looking at a lens that claims to have better intermediate vision, make sure you're leveling the playing field by either checking their vision through the phoropter at intermediate, so distance corrected intermediate visual acuity, because that's how you measure what the lens itself is doing. And the other thing is target emmetropia and see what actually is happening with emmetropia. Now, when you do mini monovision, which you can do, you're really getting an outcome based on your targeting, not necessarily the lens. And so, just the word of caution is, if you're getting intermediate vision or uncorrected intermediate vision, but you're also utilizing mini monovision, you may actually just be measuring your targeting, not actually the IOL.